Hello, I'm Brenna Macmillan, and this is my paradigm case analysis. About 3 years ago, which was a couple of years after I graduated with my associate's degree in nursing, I was working in the emergency room. Had just come on to night shift, and I had just received this patient from a day shift nurse, and this nurse had this patient in what we call our ambulance holding area. So the ambulance had brought the patient in and they were just waiting for a regular bed in the emergency room. So this nurse, um, they checked the patient in and took her vital signs, but they didn't do any other patient care. When she came to me, she was covered in bed bugs and feces. She was hypotensive and septic. So me and a coworker took her to our decontamination room and we gave her a full bath and a clean gown and we got all the bed bugs off her. Later on, I realized it had been a while since I had checked her temperature because I was too focused on her low blood pressure, but I found out that she also had a low temperature. This was one of those nights that I was never able to leave my patient's room except to go grab more medication that the doctor had ordered. It was just a stressful night and I was worried about the patient. So because of her sepsis, we were giving her lots of fluid boluses. She needed a central line and antibiotics. Later, I found out that her family hadn't called or checked on her in several days. She had fallen at home and she was down for an unknown amount of time. Um, I think this made me more diligent with in my professional life. I think this made me more diligent with checking vital signs more frequently and doing better patient assessments. And then in my personal life, it just made me want to call my grandparents more often. I was pretty disappointed in the nurse that had this patient before me because he was also supposed to be taking care of this patient. She was under this nurse's care for several hours and nothing had been done. He could have at least cleaned her up or taken her to give her a bath and get the bed bugs off, but he just kept her sitting in her bed while he didn't do anything for her. He checked her vital signs every now and then, but I guess he didn't check a temperature because he something should have been done about her blood pressure and her temperature. I was concerned with her overall health and well-being, and it was just one of those situations that made me nervous and not want to leave her side. Some ethical considerations that I had started with giving her a bath. That was the first thing I did because I couldn't let her sit in her own feces and bed bugs any longer. I still don't understand how her previous nurse was able to not do that for her. According to the ANA, American Nurses Association Code of Ethics, we as nurses are responsible for practicing within our scope of education. If I were to practice outside of my scope, this would violate ethical standards in the law. Provision 1.1 is respect for human dignity. Provision 1.3 is the nature of health. And Provision 3.2, advocating for persons who receive nursing care. I think the previous nurse breached all of these ethical standards. He thought that because this patient was in the ambulance holding area, that he couldn't give her care, which is so not true. He could have advocated for her. He could have gone to his charge nurse and explained that she needs high priority and needs to be moved to a regular room ASAP. I learned that not every nurse has a compassionate or caring heart. The patient was being treated for sepsis. I don't know what caused it, but it could have been an untreated UTI. She was down on the ground for an unknown amount of time. It's possible that she had urinated and caused a UTI and just wasn't treated properly because no one was there to check on her. Sepsis is a life-threatening condition that causes the body to respond poorly and it can shut down your organs. This is what caused her low blood pressure, resulting in the need for a central line. Her veins were not very good, so her IV access wasn't great. So the doctor did have to come in and place a central line. I gave her a 3-liter fluid bolus. I gave her antibiotics. I drew blood cultures, and I did a series of 3 lactic acid blood levels. For her hypothermia, I kept her warm under a warming blanket. I monitored her urine output I placed a temperature probe Foley because that is to me, that's the most accurate way to get a good temperature. and you don't have to physically check it every so often. It just automatically does it for you. So it's more accurate and more just accurate as far as what time her temperature was a certain temperature. The patient was mildly confused. She didn't really speak very much. She kind of had a flat affect. I'm sure she was just she could have had some dementia. I don't exactly remember, but I'm sure that she was just a little bit shell shocked being in the hospital after being at home alone for so long. She did seem more alert and happier when her family arrived. I used critical thinking to explore why she might have become septic and why her temperature was low. And I thought about what can I do to treat and monitor that more closely. And that's where the symptoms came along and um, where the temperature probe fully came in. The problem was sepsis, probably from an issue caused by her being alone on the ground for multiple days, unable to care for herself. For data collection, I collected her vitals. She had a low blood pressure and low temperature. And what was her initial assessment? She was very dirty and mangled. She had unkempt hair. For hypothesis testing, I came up with, does her poor hygiene and sepsis correlate with a new self-care deficit? My moral reasoning, despite her physical signs of neglect, it was still my moral duty to treat this patient with respect and to help her regain her dignity. I'm sure that's embarrassing to just be on the ground in your own feces and bed bugs, so it's my job to get her cleaned up and make her feel good again. For her clinical assessment, I checked her vital signs, her blood values, I did a thorough physical exam, and I thought about her environmental factors. Her hypotension and hypothermia were indicative signs of sepsis that needed to be treated. I gave fluid boluses and a warming blanket. For her lab values, I drew blood cultures and she had an elevated lactic acid level, so we treated that with antibiotics and of course the 3,000-liter fluid bolus. Sorry, 3-liter fluid bolus. On her physical exam, her hair was unkempt and she was covered in feces and bed bugs. I cleaned her up and performed basic hygiene practice. And I'm sure that instantly just made her feel better. It would make me feel better. Environmental factors. She lived alone. She hadn't been checked on in several days. She could have suffered a fall. If she were to recover from that, she would need full-time assistance and care. My previous experience as a nurse, in the past, at this point in my career, I had had patients that were septic. I had had patients that had mobility issues. And I had had patients with poor hygiene. I had never had one patient with all three of those issues, but having those patients in the past definitely helped me to come up with better critical thinking skills and know what this woman's plan of care was going to be. For my development as a nurse, according to the novice to expert theory, I would say that I am somewhere between competent and proficient. When I first started working as a brand new LPN, I would consider myself a novice nurse. I was very task oriented. I would give medications and I did wound care just according to whenever the computer told me it was time. I didn't know how to think outside the box and think about time management. Once I had been on this same med surg floor for a couple of years, I considered myself an advanced beginner. Once I had a little bit more experience, especially on nights when I had the same patients the whole week, I was able to form good patterns and manage my time better, especially with medication passes. After this, I worked in the emergency room, and once I had been there for a couple of years, I considered myself to be competent. I had a whole new skill set and I became more organized and I knew how to prepare for incoming patients. In the ER, you get told what kind of patient is coming in, whether it's a chest pain or a stroke alert or a motor vehicle crash. And each time I got told what was coming in, I just knew what to prepare for and what equipment to have in the room for each patient. I've now been an OR nurse for over 2 years. So This technically doesn't fall under the proficient category because it hasn't been over 3 years, but I do consider myself proficient as an OR nurse because I know exactly what to expect and what to anticipate for the patients for each surgical case, and I know how to determine their needs better. I haven't reached the expert level yet, but I love my job as an OR nurse, so I hope to one day be there for many, many more years and reach that expert level. With this patient scenario, some broader healthcare issues that we had, bed bugs are an environmental hazard in the hospital, and they needed to be properly disposed of. She was down for an unknown amount of time due to lack of help at home. And there were also some ethical challenges, such as not judging her family. I don't know the whole story and I don't know their family situation, but from the outside looking in, it was hard to not judge her daughters for not being there to check on her.